The FRC is the place where people can go in, they're trusted in the community, they're non-judgmental, people feel comfortable going in, and it's that familiarity of going in, having the cup of tea, but also availing of the other services as well.
Hello and welcome to another episode of the HSE Talking Health and Wellbeing podcast. My name is Fergal Fox and today we're speaking about family resource centres and the great work they do in supporting health and wellbeing right across the country. Delighted to welcome Fergal Landy, CEO of the National Family Resource Centre Forum, and Shauna Diamond, their National Programme Lead, to the podcast today. You're very welcome.
Thanks for having us.
So you're going to tell us a bit about the Family Resource Centre's work, and I know that you're really heavily invested in health and wellbeing and you're located in areas that need that health and wellbeing investment. Fergal, can you tell me what is the core business of Family Resource Centres?
Ultimately, if you were to put it in one word, place is the core business of Family Resource Centres. We have 121 family resource centres around the country, as you say, dotted in different types of communities, rural communities, urban communities, communities that are specifically disadvantaged, but also, I think more recently now, we have all sorts of mixes of backgrounds in communities. So in a place, a community, it's great to have an open door place where everyone is welcome, a building that is staffed with professional support and empowering support. It doesn't matter whether you're a young family, maybe new to parenting without a lot of family support in the area, or whether you're a single adult experiencing isolation or loneliness and wanting to be part of something, or indeed older people. We have a lot of groups and individual supports for older people. So probably what is unique is that kind of cradle to the grave approach. We're there for everyone in the community. We're of the community. I suppose that's the other unique thing about family resource centres, in that whilst I'm the CEO of the national body, each individual family resource centre is independent and autonomous and is not accountable to me. They're actually accountable to their community. And they have a board of management at local level made up of that community. So they're leveraging a variety of funding, including a lot of very welcome funding on health and wellbeing through the HSE, and they're leveraging that down. And whilst the different streams of funding might come, some from health, some from children and families, some through education, local authority, whatever it might be, that all gets pooled into one family resource centre, who can then offer a very integrated range of supports and services to their particular community. And so it's not homogenous. Not every FRC does exactly the same thing because they're doing what they have identified in partnership with the community is needed. If that wasn't there, the funding they leverage into that community might be a lot harder to come by if you didn't have that mechanism for drawing in those supports.
Yeah, I think from our point of view, family resource centres are seen to be in communities where they're needed. When we go and try and develop a strategy around or a plan around improving health and wellbeing of any topic, we always are looking for what partners can give us reach into communities that need it the most. And that's why family resource centres exist. They're not created for nothing. We work hugely on that partnership model. And so do you outline their different sources of funding. So there's local volunteers and local responsiveness to each family resource centre. That is very unique.
Exactly, yeah. And a lot of family resource centres first came about in that way. So as you say, there was a need identified in the community. A group of people came together. They formed initially maybe a committee. This is going back now to the early days of the programme. They would have been supported then to incorporate as a company limited by guarantee, develop a strategic plan based on a community needs analysis done with very participatory methods with members of the community, things like interviewing all the households in the community, focus groups, but also using the data that we have now. And we have much better data these days about the nature and profile of need in the communities through the CEO, but also open data available from organisations like the HSE. So if there is a need for a breastfeeding group in your community, then that's something you can go about and create, and you can leverage funding or whatever is required, and you can partner with the HSE or with the breastfeeding support organisations to put something like that in place. So you can be more agile than maybe a national centralised organisation. You can be responsive to what's going on in a particular community at a particular moment in time.
So some of the vulnerabilities that you referenced there, I know you mentioned cradle to the grave, but some of the key groups that are walking in the door looking for support would be that mothers, parents, children, vulnerable older people. So you seem to have a very broad span there. But in terms of the family and parenting advice, how would you see that being supported in the FRCs?
Yeah, I mean, that would certainly be a central element to what we do. And again, some family resource centres, depending on local need, might also be the location of the local community-based not-for-profit childcare facility. So that obviously creates a point of contact at pick up and drop off. But even if they're not directly delivering childcare, all FRCs would have a family support worker, would deliver a range of parenting programs, some funded through Sláintecare Healthy Communities. So really the model of universal prevention and early intervention. One of our family resource centres in Hill Street, Eileen, the manager there, would really synopsise progressive universalism, as we would call it, very well by saying help for all, but more help for those who need it most. So we can do the universal, everybody is welcome. But once you establish relationships within the community, you can very much do the targeted top-up supports as well. So everyone is coming through the door, but one parent might be getting a lot more support than another parent, but nobody needs to know that necessarily within the community. So, you never want to be the place where nobody goes, because that's where people go if they have a serious problem. You could be going in literally to avail of like free photocopying or support in preparing for a job interview. You could be going to yoga and so on, parent and toddler group. But you could be going to that parent and toddler group and then staying on afterwards and having a one-to-one chat with the family support worker. So I suppose we find that model of family support delivery and parenting support is very accessible. It's non-threatening.
It's disappointing to say there's still a bit of a stigma around accessing some supports. Sláintecare Health Communities one have been our key health inequality initiatives over the last couple of years. And having partners like family resource centres, like I said earlier on, they're place-based for a reason, but you've been able to support HSE in terms of upscaling the delivery of the parenting programmes, and that's been very good.
Yeah, absolutely. Again, it goes back to the non-stigma. And I mean this again in an entirely respectful way, but obviously we work very closely with Tusla and the Child and Family Agency, and we receive funding from that avenue as well. But I think what our involvement with HSE and Health and Wellbeing and Sláintecare Healthy Communities has just allowed us to have that balance there, because generally in the public eye, I suppose Tusla would be perceived as an organisation that are dealing with families where there's concerns for the protection and welfare of the child, and rightly so. And many of our members are involved in working with those families alongside our colleagues in Tusla. But by being involved in more broad-based parenting supports and health initiatives, that really helps just balance that out. So you're, again, not overly perceived as dealing with a problem orientation or an issue or a concern. You're there for everybody in the community. So I think being able to be involved in those types of programs. We're also really looking at, and we're doing a piece of research this year from the Government What Works Fund around really developing our approach to evidence-based working and evidence-informed working, and adopting, without killing it with technical language, looking at implementation science and blending our grassroots community development approach with cutting-edge research around the effectiveness of parenting programs. And what a lot of the research says as well is, like, a parenting program could be as effective as you want, but if the uptake isn't there in the community, then it's not actually hitting the people that you need it to hit. So by being able to combine the credibility and the relationships that our members have within their communities with research coming from universities and all the different think tanks that create research around effective parenting programs and other intervention programs, we can kind of be there as the bridge between the two. And Sláintecare Healthy Communities has been that in some ways by having requirements in relation to the evidence level of parenting programs, tuning us into that. So you're not just delivering a parenting program, you're delivering a parenting program that has a sufficient level of evidence about its effectiveness as delivered elsewhere, and you're bringing to bear the characteristics of that program that are deemed to be effective and bringing it to the families who need it.
Yeah, bringing an evidence-based program into an evidence-informed practice.
Exactly, yeah. So this research we're doing at the moment, we're calling it a community development approach to evidence-based and evidence-informed practice. So what works for communities? So we're sort of reframing it, because at the end of the day, it is important what works from a technical point of view and so on. But as I say, if it doesn't flow in the community, then that's just academic, because nobody's actually going. Maybe I was involved back in the 2000s when we took a lot of evidence-based programs from the States that came with very high levels of research evidence around randomized controlled trials. But again, if you can't adapt that appropriately to the cultural context and the local context that you want it to be delivered in, then again, with all the bells and whistles, it doesn't matter, because nobody's going or the right families aren't going. And again, you talk about need. I mean, it's quite right that families with capacity and with social capital will seek out support sometimes. And I've certainly had one anecdote of a family resource centre rolling out kind of infant massage program, and some cars rolling up from maybe down the road that were brand new fancy cars that they'd never seen before. So in other words, people with social capital will seek out the supports they need. This works both ways. So those families were more than welcome. But if you don't have someone making sure that the families that don't always get themselves there, or maybe even need someone to call down for them, give them a lift up or give them a nudge or send them a text, and are you coming up for that group we're having this morning? Then those are the types of families that don't uptake on these programs. And then the whole early intervention, late intervention concept, when that's left unaddressed over a period of time, those are the types of families that start coming on the radar of our secondary and tertiary services. both for the HSE and for Tusla. Plenty of work can be done. I always espouse like a hopeful approach for those families, but the evidence is there that you have a much better percentage chance of helping that family if you intervene early and mitigate the problem before it becomes significant, both early in the problem but also early in the life of the child. So getting in with those children. Because what you find, I think, a bit in Ireland, and it's a good thing that we've a constitutional right to free primary school education, but sometimes the state help apparatus is only brought to bear when children are hitting primary school. The evidence from neuroscience and from prevention and early intervention research is, whilst that's welcome, it's much sooner that you need to be getting in. And really, you're looking at programs now that wrap around a family from the point of conception through the pregnancy in the first 100 days after childbirth, and then shepherds them along to through early years care and education. And then they're starting school, hopefully on a fairly level playing field with some of their peers. Famous research done years ago that kids starting junior infants had certain cohorts have so many words in their vocabulary versus other cohorts.
I'm just reminded of what you said earlier about the progressive universalism. I didn't appreciate the benefit of those wider targeted programs to place ye in broad engagement opportunity as well as the need, like in terms of that triangle, you have things on the bottom for everybody and you have some services and supports from the top of the people that really need it. Social prescribing is another initiative through Sláinte Health Communities that you've supported in some places, and that's definitely well connected to your fundamental delivery of connecting people, isn't it, Shauna?
It is, yes. We partnered with Sláinte Care, I think in 2019 for the Integration Fund, and we piloted social prescribing in 10 sites. So subsequently then we partnered with Cork and Kerry Community Healthcare through the HSE, and we have 3 full-time equivalents in Cork and Kerry and 7 part-time social prescribers down there. The beauty of having social prescribing in an FRC is it's the opportunity for someone to come in and obviously to meet the link worker, to work through that, understanding what are their needs, looking at their strengths and working through the process of social prescribing. But it's so much more than that, because social prescribing in an FRC has the opportunity for people to avail of step down, so some group supports, but also then to actually for step-up supports, as I would call them. So there's the opportunity if someone is going through a really difficult time and they've worked through the social prescribing, but they actually need a little bit more support, there's the opportunity in FRCs to avail of counselling. So close to 100 of our FRCs around the country actually have a counselling service. This is available for young people, but also for adults as well. So the social prescribing can tap into the other opportunities in FRCs as well. So as a good example, I was just talking to our regional coordinator, Rita Bevan, who coordinates the 10 social prescribing sites in Cork and Kerry. And she was telling me about this parent who came in to use the service. They were going through a difficult time because they had 2 children with additional needs and they were feeling overwhelmed, feeling a bit down on themselves, and they were just really struggling. So they came in and used the social prescribing service. But after the couple of sessions with the link worker, they realised actually there's so much more going on at home. So, it turned out that actually the father wanted a bit more support around parenting, so they availed of the parenting programme, but also then that mum needed help with some MABs, so the money advice and budgeting service, and also then for some counselling for herself as well. So you can think of social prescribing as an intervention, 8 meetups with the link worker, and if only life was so simple that you started at A and ended up at C, but actually you can meander along the way. And I think the social prescribing gives the opportunity for the person to come along to actually explore what their needs are.
Yeah, it's nearly given space. And then FRCs could be seen as like a social prescribing space fundamentally, because you're looking to support people and looking to gain a bit of trust.
Yeah.
And signpost and support as appropriate. So it's nearly like that's the default.
Exactly. And actually, do you know what? When social prescribing came really popular in the last number of years, a lot of our FRCs were saying, we do this, but we don't really have the resource or the time. So the benefit of having the funding from the HSE is actually, obviously, we have link workers based in family resource centres who can give the time to the individual to come in, have the hour and explore where they're at and what are their needs. So we're very grateful for the partnership. And I'm just using Cork and Kerry as one example, but there's 30 family resource centres around the country that are funded through the HSE that have social prescribing link workers in post.
Very good. I heard from our New Year's episode, we had Sean Keneally on from Mayo, and he was telling me about the partnership that the smoking cessation service over in the West have put some of their smoking cessation staff into the family resource centres on a day a week or an afternoon, trying to target your neighbourhoods and your areas with smoking cessation supports, because obviously, unfortunately, there's higher rates of smoking in more deprived areas. And smoking is still it's a massive priority for the HSE, and it's the number one thing you can do if you're a smoker to improve your health and well-being. So that's another example of a partnership where the HSE has taken an advantage or taken the opportunity of getting access to family resource centres physically, and then the communities. I'm sure you've heard about that one as well.
Yeah, absolutely. I mean, again, it's another example of our members participating with partners such as the HSE in providing that space for initiatives like smoking cessation to happen. And you're quite right. I mean, again, it's not to make it sound in any way stigmatising, but it can be an indicator, I suppose, of other problems going on in a family's life, in an individual's life, in young people who smoke. It tends to coexist with other social and emotional behaviour problems. So I think by offering that and people coming in and uptaking on that, hopefully they will uptake on that successfully and they'll manage to kick the cigarettes. But it may actually be that there's other things going on for the same cohort of people who need to avail of that. So when they come in, the opportunity for them to avail of other mental health promotion initiatives, again, parenting or family support, whatever it might be, as distinct from you could run that anywhere, I suppose, if all you were looking for was a building. But when you have a room that's within a building where all these other activities and supports are being offered, you're increasing the likelihood all the time of those who most need it uptaking on the supports that are there, because we know the supports are there. At the end of the day, there is a level of funding there, but it's the uptake on that funding and the supports and services that are offered. So I think
that's the same case for us. In terms of the HSE, we have a quit support service, we have smoking cessation support staff, but it's to get the engagement. And you mentioned earlier on there, Shauna, about the space, for a social prescriber, the space for a smoking cessation officer or a smoking cessation advisor to spend time with somebody and just go through what's going on. When you do that one-to-one smoking cessation, there's a lot of other conversation topics other than the tobacco and the nicotine addiction. So it's about creating the space. And as you said there, Fergal, loads of other things come up, but you're in a space where there's other supports being provided.
Yeah, that same logic would apply a lot, Fergal, to childhood obesity. A lot of our members like the Healthy Food Made Easy programme, because again, it combines very well with parenting and family support. So somebody might come in for a cookery class, and through that engagement, it's great. First and foremost, the primary outcome is learning how to cook healthy food for their family, but effective family functioning happens around the dinner table. And in some ways, a family sitting around together and having a healthy meal is a really good, positive indicator of positive relationships within the family. And if that's not going well for any reason, again, if that emerges through the Healthy Food Made Easy programme, there's the opportunity to add on parenting and family supports alongside that.
My colleagues in the National Office for Suicide Prevention were also highlighting how one of the early pieces you adopted from the HSE was mental health and suicide prevention a couple of years ago in your own framework. Shauna, you were heavily involved in that at the time.
I was indeed. I think we have been a partner with NOSP since 2012. So they funded the Suicide Prevention Code of Practice, and actually the Suicide Prevention Code of Practice emerged from a local need. So you're talking about people coming together. And it was in 2011, family resource centres in the west of Ireland realised there's been an increase in suicide in the area. People are presenting to the family resource centre. We don't really know how to respond. Let's do something about it. So the family resource centres came together and they developed the Code of Practice. And subsequently, NOSP funded the National Forum to deliver it nationally. So we are partners in Connection for Life. We have the Suicide Prevention Code of Practice that family resource centres are trained up on, so they know how to identify someone who may be presenting who is suicidal and how to respond appropriately then, and then also to look after themselves in the aftermath of an incident, if that is the case. And we also then have an online programme, so the E-Code of Practice. So that has only been launched there 2 weeks ago, actually. And it's a really positive piece of work, because what we want to do is actually, when new staff member joins the Family Resource Centre programme or the voluntary boards, as Fergal spoke about earlier, that everyone actually receives this online training first, so that they have a baseline understanding of this is how we work. When someone presents with suicidal ideation, that we're able to respond, and we have the supports in-house to be able to support that person and then subsequently signpost them on.
Yeah, that's so important, isn't it? That knowledge and that capacity to support wherever possible. And sadly, when there is an incident, I'm guessing the family resource centre is going to have to pick up the pieces for a long time. So it's very important to be at that prevention point. I heard a lovely piece, it was one of the videos to your staff from Hillview Family Resource Centre talking about the impact of the Let's Talk About Suicide training that they've done, that online training that the National Office launched last year. And we just have a little listen to their piece. They're just discussing the impact of the training, which is connected obviously to your framework and your code of practice. Just listen to the impact that that's had for them. So that was Sinead Jones and Brenda Lee from the Hillview Family Resource Centre, and they were just talking about the training that can be accessed. It can be accessed for everybody, but the Family Resource staff are highlighting how they're implemented. If anybody wants to access that training, that's at traininghub.nosp.ie, and we'll put all the links, as we always do, in the podcast information section, wherever you're listening to this podcast. But that really hit home to me. The staff really can see how they can utilise this training and integrate it into their work.
Yeah, and I think it goes back to the fact people come into a family resource centre, they know they're not going to be judged. It's a trust and open space. So these types of conversations can happen, and they could happen with an administrator, a community development worker. It could be anyone within the family resource centre. So it's really important that people feel comfortable to ask the questions, that they are able to validate the person when they're being open to them, and feeling that they are equipped really to support the person or signpost them on. So, yeah.
Yeah, rolling out that bit of training, which I know you were heavily involved in, Shauna, you must have seen that you're giving people a framework and real confidence to be able to do that engagement. Just listening to Brenda and Sinead, they can really stand up over their work. They're put in a vulnerable position when you're meeting so many vulnerabilities coming in the door.
Yeah, it's all about being comfortable and confident in asking the question, I think. And what we would always say is avoiding it is probably the worst thing you can do. So, at least with the training from the HSE and also with our Suicide Prevention Code of Practice, we're confident that staff within the family resource centres are able to ask those questions. And if it's a sensitive issue for them, that there's someone else that they can hand it over to. So that person is not left and is not left wondering or left without support. So that's the bottom line, really.
Yeah, Fergal.
I was just going to say, I think as well, because of that mental health project and the suicide prevention work, again, that's happened over the years, is going back to the early days of the Family Resource Centre National Programme. Under the Family Support Agency at that time, we would have had counselling grants related to effective family functioning. So a certain significant amount of family resource centres are offering counselling and psychotherapy, both for adults and for children. So again, as we began to confidently move into the mental health sphere, we also have relevant supports and services that we can offer alongside that. So we are the broker sometimes between informal supports and formal supports, and sometimes, thankfully, as a result of that training, people will be clear on when to refer on. But also there are supports within the mental health arena that we can actually offer, again, on that same logic that I mentioned earlier around prevention and early intervention. So we know people talk about the experience of when they get into the health system, they have a very good experience. But it might be that if somebody can avail of easily accessed, with very little waiting lists, localised counselling or group therapy, that they might be less likely then, hopefully, if that's successful, to need the more formal health services that can be more difficult to access on occasion. And one thing we'll be involved in this year now is with our colleagues in the HSE and Child and Adolescent Mental Health Services are developing a single point of access for referrals to CAMHS. So we'll be collaborating with the HSE on that, on some pilot initiatives whereby children who are referred to CAMHS by, say, their GP can avail of the types of supports and services that we offer while they're waiting to be seen by CAMHS.
Yeah, that's very important. One of the areas you mentioned previously to me that you're developing a service around is around gambling. And this has come up on a couple of our podcasts as an emerging issue, an emerging awareness for young people and adults, but impacting on community. I know it's come up in our podcast, one of the early podcasts we had at the GAA. They said it's a massive issue. With Spun Out, the National Youth Website and Support Organisation, they said it's a massive issue in terms of young people that are seeking support from them and advice around gambling. Can you tell me what you're doing in that space?
Yeah, so a few years back, and Shauna was quite involved at the time as well, an opportunity came our way alongside, a sense that this was an issue, maybe somewhat a hidden issue, hard to reach kind of an issue, increasingly in rural Ireland as well as in more urban communities. What has changed in the last few years is the whole role of social media and smartphones and the interface between that and the gambling industry. So an opportunity came for us to avail of funding through the Gambling Awareness Trust to set up effectively a national problem gambling support service, supporting problem gamblers, but also, and importantly, those affected in their family and extended family. And again, very similar to everything we talked about earlier, as people are coming into Family Resource Centre, as people are availing of other supports and services, we are well placed to offer alongside that a specific service around problem gambling. So we have therapists that can offer a specialist form of counselling and therapy for problem gamblers. But then we also have the whole array of wraparound supports and services that we can offer to their family as well. And I think we found in the early days of that project, and Shauna can speak a bit more about it, but it was a slow burner in the sense of getting people to refer, getting people to come forward, either the gambler themselves to come forward and admit they had the problem, or for their family members to seek help as well. but it shows the value of sticking with something like that, because after those early days, and a lot of the staff that were hired through that project did a certain amount of awareness raising work, doing talks in communities and schools and so on, so making people aware of the existence of the service. And slowly but surely then the level of referrals has increased to the point now that really what we'll be looking at over the coming years is how we need to get additional resources to meet the level of demand that's coming forward.
Yeah, to kind of build trust and awareness as part of establishing that service.
Yeah.
We mentioned a bit of stigma before about things, but that is definitely a challenging one to come out. And
I think there's certain, and I'm sure local FRCs will be able to word this well, but there's certain services you could offer out and, your door might be beaten down the next day or the next week as soon as you offer it, because they're popular or people are happy to seek them out very proactively. But then I think services like this, they're really, really important, but you do have to have a degree of patience and you have to have the capacity to outreach into the community as well.
Yeah, so we're just finishing up a 3-year pilot. So for the first year to 2 years, the majority of people availing of the service were what I would call concerned significant others or family members.
Okay.
But that has changed now. So in the last year, there was nearly 800 people availed of the service. It's across 19 counties and in 23 family resource centres. And I think about 3,300 therapy sessions were delivered last year alone. And we've seen this trend grow year on year. So I expect this year as well.
You have people in the resource centre. It's not remote.
Yes. It's in the resource centre. And also the opportunity to avail of this service online is there. So the beauty of Zoom has really opened up the space for people where that stigma is just too much to go through the doors of your local family resource centre. Now, bearing in mind, it could be for anything, but that stigma still is there.
Yeah.
So we do offer the online service as well. So if someone wanted online therapy for harmful gambling, they would be able to avail of that as well.
So you've seen the growth and you think this is an area that you're going to be establishing a service on an ongoing basis with?
Yeah, we will be working really hard to evidence the work now. So we're working on an evaluation currently. So to demonstrate the impacts of this service and actually the ever-growing need now. So even just talking about the types of people who are using the service over the last year, it would be males predominantly now in age 25 to 44, kind of the cohort that are striking the most. But also the types of gambling that they're engaging in is really interesting. So depending on the age cohort, you can see what type of gambling. And it's the gaming now, it's the online gambling. It's becoming harmful for them and their families.
Yeah, it's so accessible, like Fergal was saying. So look at, as we move towards the end of this podcast, is there any other area of development that you'd like to highlight to our listeners and your own communities through the podcast?
Yeah, look, we've such a range and gamut of supports and services. We're probably not going to cover everything today, but from engaging with family resource centres around the country, there's probably 2 particular areas that are coming to the fore of late. The first one, I suppose, is kind of a product of the cost of living crisis that we're all aware of. So it started around the time of COVID as an emergency response. A lot of our members got involved in addressing food poverty in the local community and offering food banks. And more recently now, we've become involved in period poverty and menstrual health as well through funding from the Department of Health. So meeting those immediate needs is something that family resource centres do. And we did have a lot of internal discussion about it, because we are very much committed to what we call a human rights-based approach to community development and family support across the life course. So we're sort of extremely reluctant to become a sticky plaster on what we would see as the symptoms of poverty and inequality in our communities. But we're also very clear that we have to meet people where they're at. So what we do is really a community development approach to a food bank, as opposed to maybe what you might call the traditional charitable model. So Packy, one of our FRC managers in Monaghan, talks about how the food bank and the information and the data about the use of the food bank is extremely useful in their advocacy work around challenging poverty and inequality. So more and more of our members are getting involved in that. And we've certainly had some discussions at government level about the role we can play, because we always offered summer programmes. And holiday hunger is becoming a bit of an issue now in some communities around the country. So the fact that we're offering summer programs, summer camps, activities, again, in a very local and accessible way, means that we can be there for families who might be experiencing food poverty, because people are aware of the schools program. But again, schools program's not everywhere yet. And even so, holiday hunger then remains an issue when you have that. The other thing that's become to the fore for our members in recent years, and they really brought to us, was the whole issue of the role that we play with new communities. And again, we had a lot of very particular discussion internally. We talked, and we had our most recent national conference at the end of last year around our role in intercultural practice and building cohesive communities. And we really framed that within the content. And we had Martin Collins from Pavey Point with us. So we're really talking about intercultural practice as it relates to the established traveller community, but also the migrant communities that are joining our
Well, I
communities.
suppose that's out of necessity, isn't as well, in terms of the communities that are coming in the door.
Absolutely. So FRCs, again, there's no dedicated stream of funding for this type of work, but FRCs, where there are IPAS centres, when the war in Ukraine initially commenced, FRCs were absolutely at the coalface. I mean, literally meeting people off of buses as they arrived into communities. And that started as an immediate need thing, responding to the immediate needs of those communities. But very quickly it became as well a responsible mediator of some of the divisive rhetoric that was happening within communities. And we've done some training with our members in partnership with the Hope and Courage Collective and with Community Work Ireland. It's almost similar to the early intervention versus late intervention model. Our members are telling us if we are proactive in community work and we're having conversations about migration, the global trends of migration, and also while we're doing that, we're building relationships within communities, and we're doing that ahead of anyone who might seek to offer a more divisive narrative within the community. We're actually then a centre of credibility to talk to people about how to navigate those situations, but ultimately to build the community together. And we were approached by an existing initiative set up by Graham Clifford, who set up the Sanctuary Runners. He had also set up an initiative called One Town, One Voice, which is kind of informal singing groups for everybody in the community. Really, it's put out there who would like to come and sing. You don't have to be a good singer. It's not a choir. It's not about that. I've joined in a few times myself, so that's evidence enough of that. I went down to Fermoy to the original one, and you literally have maybe 80-year-old Mrs. Murphy down the road with maybe a young Ethiopian or Eritrean man who might have arrived in the previous year into the community, singing songs together, singing pop songs, singing traditional Irish songs, singing African songs, singing Ukrainian songs. And it really is an amazing soft measure for building that community cohesion, because ultimately, when you have those human interactions and those human relationships, I think you're much less likely then to leave the vacuum into which the more divisive rhetoric can come. And if you're ahead of it, again, and intervening early to address the need for community cohesion. We can't forget that a lot of that kind of the funding for frontline community development work was cut at the time of the recession. And I think we're really seeing the symptoms of some of those cuts now. So, we would work with our partners in Community Work Ireland and other espousers of community work and partnership companies and so on. That really that type of work. We see that the state requires interventionism, it requires casework and one-to-one work. But that kind of community work is really important as well.
Thank you, Fergal. That's a lovely piece that you mentioned there about One Town, One Voice. It really has the potential to break down barriers. And I hear you in terms of the community development funding need and the resource in those communities. But look, I really want to thank you as we finish up today, Fergal Landy and Shauna Diamond from the Family Resource Centre National Forum. I really want to appreciate your input today. Thanks for coming along to the podcast.
Thanks, Fergal.
Thanks.
And to all our listeners, thank you for your continued support of the podcast. Please share this episode with anybody you think would get value out of it. And please leave us a rating on the podcast channel you're listening to us on. As I said earlier, the information links to the Family Resource Centre website and the links that we mentioned earlier are in the information section of the podcast, wherever you're listening to this. If you want to contact us, send us an email at healthandwellbeing.communications@hse.ie. And thank you for listening to the HSE Talking Health and Wellbeing podcast.